Welcome back to the new section on hypoglycemia. In the previous sections, we have discussed in detail on the glucose and metabolic pathways of glucose, and at the same time, we have discussed in detail with regards to the insulin and its action. We have also done a few videos on the classification and pathophysiology of diabetes mellitus, where understanding of the types and recognition of these in clinical practice is very important for effective treatment of those disorders as well. And we also have done a sizable number of videos on hyperglycemic emergencies and their management. This section is dedicated towards hypoglycemia because hypoglycemia is something like a neglected thing in clinical practice most of the times. And at the same time, prompt identification and treatment of hypoglycemia is important because otherwise you would result in a long-term adverse neurological outcome. And sometimes prolonged hypoglycemia can result in sudden death in terms of cardiac arrest and cardiac arrhythmias as well, which should be avoided in clinical practice. So I'm going to split hypoglycemia into 3 videos. This particular section will be on the basics of hypoglycemia. So where majority of the things we have studied in the first few videos of insulin and glucose is going to be helpful, and I'm going to integrate in a very quick and a brief manner. And the next subsequent video will be on the approach and the etiology of hypoglycemia in children and infants, and the final and the third subsequent video will be on approach and diagnosis of hypoglycemia in adults with and without diabetes mellitus. As I told, hypoglycemia very commonly happens in the setting of diabetes mellitus, especially when they're taking insulin or insulin secretagogues, but it can happen in a small proportion of individuals without diabetes mellitus as well. So we have to keep that in mind. So with that basics, let us go on to the basics of hypoglycemia and start with the fuels that are utilized by different cells and tissues in the body. First of all, you have to understand that glucose is going to be the preferred fuel. Under any circumstances, if glucose is available, that's going to be the first line and the preferred fuel for any tissue or cell in the body. But if the patient is fasting or if the blood glucose levels are dropping, then certain organs try to use alternative fuels and preserve glucose for very important organs like brain and RBCs, where RBCs cannot use any other fuel apart from glucose. So now the muscle starts utilizing free fatty acids, the liver starts utilizing free fatty acids, and adipose also starts utilizing free fatty acids because all these organs try to conserve glucose for the brain and of course for the RBCs as well. And if the situation gets worse and if the person is not taking sufficient feeds for a longer period of time, then the liver is going to proportionately increase the production of ketone bodies through different pathways. And these ketone bodies that are produced can be utilized by the muscle, and at the same time, these ketone bodies can be utilized by the brain as well. So why brain is shunting its metabolism towards ketone bodies in extreme scenarios? Because the glucose that brain now is going to preserve is going to be utilized by the RBCs, because RBCs with the table I have given is going to exclusively thrive on glucose alone because they don't have the metabolic machinery to assimilate free fatty acids or ketone bodies, because ultimately free fatty acids and ketone bodies will be resulting in production of acetyl-CoA that has to be degraded in the mitochondria to produce energy in ATP. Since RBCs do not contain mitochondria, they cannot use this acetyl-CoA that are coming from free fatty acids and ketone bodies, and hence glucose is going to be the primary fuel and glycolysis is going to be the only metabolic pathway in RBCs to produce energy. So that's why till the death, till the final stage, RBCs are going to use only glucose. Remember, the brain cannot utilize free fatty acids. It's a very important point. Whereas liver and adipose tissue are not going to use ketone bodies. Ironically, even though the liver is the one that produces ketone bodies, but liver does not usually utilize the ketone bodies. They are going to utilize free fatty acids only. But muscle is the only organ which can utilize all the 3 different types of fuel, the glucose, free fatty acids, as well as the ketone bodies. RBCs can utilize only the glucose. Liver and the adipose cannot use ketone bodies, and brain cannot use free fatty acids. So these are the things in a nutshell. Then let us move on to the biochemical defenses that a person develops in response to hypoglycemia and low blood glucose levels. So first of all, we know the first defense mechanism is glycogenolysis. Especially if the person is not taking any feeds for a period of 4 to 6 hours, your glycogen will be degraded because glycogen will be produced in well-fed states, and during the early stages of fasting, around 4 to 6 hours, the glycogen is the first thing that gets degraded, and that is the one that is going to get converted to glucose, and that will be poured out from the liver into the blood to be utilized by the other organs. So later on, your gluconeogenesis, lipolysis, ketogenesis, and all this process starts kicking on, which we'll be seeing subsequently. So first of all, let us see how this process happens in a nutshell. So glucose will be converted to glycogen in well-fed states and in the presence of insulin, of course. So for production of glycogen from glucose, you need several enzymes. First of all, glucose should be converted to glucose 6-phosphate in the liver by glucokinase, and glucose 6-phosphate should be converted to glucose 1-phosphate again in the liver by an enzyme called isomerase, and glucose 1-phosphate will now undergo a series of steps to produce glycogen, and the two most important enzymes in this step is going to be glycogen synthase, which is going to be the rate limiting enzyme in this step. At the same time, this enzyme is the one that is under strong hormonal control, especially it is going to be stimulated strongly by insulin and inhibited by certain counter-regulatory hormones. But this enzyme is under strong control of insulin, we know that. And apart from that, to produce glycogen, you need to produce branching points, and this is done by another enzyme called a branching enzyme. And finally, you will result in the production of glycogen. During times of fasting, the glycogen should be mobilized to produce glucose. And production of glucose from glycogen involves a series of reactions, of which 3 enzymes are very, very crucial. The first enzyme is, of course, going to be the glycogen phosphorylase. We have a liver as well as muscle phosphorylase. But anyways, the phosphorylase enzyme is important for breaking down the bonds. And at the same time, to break down the branching points that are formed, you need another enzyme called a debrancher or a debranching enzyme. Remember, phosphorylase and debranching enzyme can only produce glucose 1-phosphate. But subsequent production of glucose 6-phosphate will be done by an enzyme called isomerase. Conversion of glucose 1-phosphate to glucose 6-phosphate by isomerase should not be a big headache because it's a reversible step catalyzed by isomerase enzyme. But once glucose 6-phosphate is formed, it has to be converted to glucose by a very special enzyme. So why? Because glucose to glucose 6-phosphate happening in glycolysis is done by glucokinase, that's most important in the liver, and hexokinase by other tissues, but that's an irreversible step. It's a one-way reaction. But this has to be reversed by a special enzyme called as glucose 6-phosphatase. And we all know the deficiency of glucose 6-phosphatase will result in something called as a von Gierke disease, and that will result in serious hypoglycemia. Why? Because this glucose 6-phosphate and glucose 6-phosphatase reaction is something can be seen as a bottleneck where multiple different highways meet at a common signal. It's like multiple different pathways are getting integrated at the glucose 6-phosphate step only. So for example, the gluconeogenic pathways will be ending at glucose 6-phosphate only, and your lipolytic pathways partially will be ending at glucose 6-phosphate only, and your fructose and galactose metabolism in times of fasting also can end up at glucose 6-phosphate. So that's why it's sort of a bottleneck, and when you have deficiency at the meeting point of different reactions, so you'll result in affection of all the reactions. That's why von Gierke disease is something that produces serious hypoglycemia. And anyways, nevertheless, once glucose is formed from glucose 6-phosphate through glucose 6-phosphatase reaction, the formed glucose will be released into the blood through a very important transporter called as GLUT2 transporters. Of course, liver takes up glucose through the GLUT2 transporters in well-fed states and the situations where you have high insulin, and in fasting states, the same hepatocytes are going to release glucose into the blood through the GLUT2 transporters, which are to be utilized by the other organs in times of low blood glucose levels. So as I told you, initial phases, glycogenolysis is going to be the most important. But as the fasting gets prolonged or the hypoglycemia gets prolonged, if the glycogen stores are getting depleted, of course, the gluconeogenesis becomes really important, which also is going to end up at the glucose 6-phosphate step. Let us see how it's going to end up. We know in glycolysis, glucose is going to produce pyruvate. But in gluconeogenesis, we are going to result in production of glucose from pyruvate. So pyruvate is the major substrate here, which is going to produce glucose, but of course through glucose 6-phosphate, through a series of reactions. And because majority of the reactions in the glycolytic pathways are basically reversible, but only 3 steps are basically irreversible, and these 3 steps has to be reversed by certain specialized enzymes. And of course, 3 irreversible steps are the pyruvate, phosphoenol pyruvate to pyruvate conversion steps done by pyruvate kinase, and fructose 6-phosphate to fructose 1,6-bisphosphate produced by fructokinase enzyme, and of course, the glucose to glucose 6-phosphate done by glucokinase enzyme. So these 3 things has to be reversed, and you need some specialized enzymes for that. To reverse the phosphoenol pyruvate step, So you need two special enzymes. One is pyruvate carboxylase, because this will convert pyruvate to oxaloacetate first, and oxaloacetate to subsequent conversion of phosphoenol pyruvate will be done by an enzyme called PepsiK, that is phosphoenol pyruvate carboxygenase. And once again, almost other reactions are reversible, but one step, that phosphofructokinase step, has to be reversed by another special enzyme called as fructose 1,6-bisphosphatase. And finally, we'll end up with glucose 6-phosphate, and this can be reversed by glucose 6-phosphatase to produce glucose, as I told previously. And all the gluconeogenic enzymes, including glucose 6-phosphatase, are under strong hormonal control, especially insulin tries to inhibit these enzymes. And counter-regulatory hormones, including cortisol, tends to stimulate these enzymes. And where the pyruvate comes from? Pyruvate comes from certain gluconeogenic substrates. So what are the gluconeogenic substrates? Of course, amino acids are gluconeogenic substrates. Commonly, most often, they end up with alanine. And the lactate is also a gluconeogenic substrate. Of course, the amino acids as well as the lactate is going to come from the muscles through two different cycles. We know that is Cahill cycle and Cori cycle are there, which I have described already in the basics video section itself. And alanine conversion to pyruvate will be done by an enzyme called alanine transaminase, otherwise called as SGPT. And the lactate conversion to pyruvate will be done by another enzyme called LDH. Even though these are reversible reactions, but there is something called a redox ratio, the NAD to NADH ratio. Depending on that, pyruvate can produce alanine and lactate, or lactate and alanine can produce pyruvate. So in energy depleted states where there are low NADH, of course, alanine and lactate will be converted to pyruvate in that setting. So for that, you have to understand what are the gluconeogenic amino acids, what are the ketogenic amino acids, and what are the combined gluconeogenic and ketogenic amino acids, because these amino acids form as substrates for gluconeogenesis. So first, let us see the ketogenic amino acids. The ketogenic amino acids are nothing but leucine and lysine. You can remember as two L's. Leucine, lysine are ketogenic amino acids. And there are some amino acids which are gluconeogenic and ketogenic. So amino acids like isoleucine, threonine, and aromatic amino acids. You know what are the aromatic amino acids? They contain the aromatic ring, the classic phenylalanine, tyrosine, and tryptophan are aromatic amino acids. All these things are combined gluconeogenic and ketogenic. And there are some amino acids which are predominantly gluconeogenic, and they are nothing but rest of the amino acids apart from what I have told in the list. So which means majority of the amino acids are basically gluconeogenic only, which can be coming from the muscle and which can be processed by the liver to produce pyruvate, which can be subsequently utilized for the gluconeogenesis to produce glucose during the fasting states and hypoglycemic states. And lipolysis can be partially linked with the gluconeogenesis and the glucose 6-phosphate step, and the link is going to come from glycerol. So we know where this glycerol is going to come from. It's going to come from triacylglycerol, of course, which is present in the adipose tissue. And triacylglycerol will be converted to glycerol and free fatty acids by a very, very important enzyme called hormone-sensitive lipase, which is, of course, under very strong hormonal control, where hormone-sensitive lipase will be inactivated to a great extent by insulin, and it can be activated by counter-regulatory hormones, including epinephrine and growth hormone. So once glycerol is formed, we know glycerol can produce glycerol 3-phosphate. Once glycerol 3-phosphate is formed, it can result in production of dihydroxyacetone phosphate, and dihydroxyacetone phosphate can be subsequently converted to glyceraldehyde 3-phosphate, and that's it. Once glyceraldehyde 3-phosphate is formed, it can be utilized in the gluconeogenic pathways, which is already going on in the liver during fasting states, to yield glucose 6-phosphate and subsequently glucose by glucose 6-phosphatase. And there is one more substance that is closely linked with the glyceraldehyde 3-phosphate and subsequent production of glucose, that is fructose metabolism. So fructose can also produce glyceraldehyde 3-phosphate, which can be later on converted to glucose by the liver in the fasting states. We know that already, and the details of which I have given in detail in the basic section itself. If you are not very sure, you can go back and watch that. So free fatty acids. What about free fatty acids? The free fatty acids that are produced by the hormone-sensitive lipase during fasting states is going to act as a source of alternate fuel. And it can be utilized by certain organs like skeletal muscle, adipose tissue, and by the liver itself. So why they are using this as a source of fuel during fasting states? Because they are going to spare glucose for other organs which are dependent on glucose, like brain and the RBCs. So how they are going to act as a source of fuel? Because this free fatty acids can be entering a process called as beta oxidation, which is basically an unregulated process not controlled by any major hormone, which can yield something called an acetyl-CoA. This acetyl-CoA has multiple functions. Remember, first of all, it's going to be a source of energy, which is going to produce ATP in the mitochondria of the organs which I mentioned already, that is the liver, adipose, and the skeletal muscle. Apart from that, this acetyl-CoA has multiple others, like in biochemical importance. Like for example, they can stimulate an enzyme called pyruvate carboxylase when they are produced in excess. So which means the gluconeogenesis also will be accelerated because acetyl-CoA is an allosteric stimulator of pyruvate carboxylase. And apart from that, acetyl-CoA can be converted to ketone bodies, and this things happen only in the liver. In the liver, they can stimulate pyruvate carboxylase. At the same time, they can produce ketone bodies from acetyl-CoA as well, like beta-hydroxybutyrate and acetoacetate. And production of ketone bodies needs some special enzymes which we have discussed already, like HMG-CoA synthase and HMG-CoA lyase. But once ketone bodies are formed, these ketone bodies can be used as a source of alternate fuel by certain organs. Like for example, the brain and for example, the muscle can utilize these ketone bodies as an alternate source of fuel at extreme states. And they're going to use these ketone bodies to produce acetyl-CoA, and acetyl-CoA will be subsequently sucked into the Krebs cycle in the mitochondria to produce energy and ATP. Even though ketone bodies are produced by the liver, you can see that the liver does not really utilize ketone bodies, and they give the ketone bodies into the blood to actually be utilized by the other organs which are in need at that time. And the final thing that is linked with the glucose 6-phosphate bottleneck is the galactose metabolism. We know galactose is going to result in production of something called a galactose 1-phosphate by an enzyme called galactokinase, which is not really important. Galactose 1-phosphate can be converted to glucose 1-phosphate. And we know how this happens. It happens through a very, very important step called GALT step, or mediated by an enzyme called GALT, which is going to convert galactose 1-phosphate to glucose 1-phosphate, because deficiency of GALT is going to result in galactosemia, which is one of the important causes of infantile hypoglycemias. And during this step, one molecule of UDP glucose will be converted to UDP galactose. We know that as well. And we have seen all these things in detail in the basic section. Once glucose 1-phosphate is formed, it's easy to form the glucose 6-phosphate through the famous isomerase enzyme, because it's a reversible step. It's not a big deal. So once again, this is ending up with the glucose 6-phosphate. So that you can see that the gluconeogenesis, galactose metabolism, lipolysis partially, and fructose metabolism, all these things are actually ending up with the glucose 6-phosphate bottleneck. So which means this glucose 6-phosphate is a sort of, common entry for multiple different reactions to produce glucose. It's important to understand one more fact, that glucose 6-phosphate enzyme is not present in the muscle basically, but it's a very, very important enzyme in the liver, of course, and liver is the powerhouse of producing glucose in times of fasting. And it can be present to a small extent in renal cortex. It can be present to a small extent in the intestine, that is the enterocytes, but definitely it is not present in the muscle. What do you mean by that? Muscles can produce glycogen from glucose during well-fed states, but during low energy states and fasting states, they cannot produce glucose from glycogen. Instead, they produce only glucose 6-phosphate, which can be utilized by themselves by using the glycolytic pathway, where glucose 6-phosphate will be taken into the glycolytic pathway to produce ATP and energy. But muscles use glucose to produce glycogen, but they cannot produce glucose to be utilized by the other organs, whereas liver does that. That's the most important point. Apart from that, let us see the response to fasting at various time scales and what is the most important biochemical pathways that's going to yield the fuel in the body. So, for example, what's going to happen in 6 hours, what's going to happen at 12 hours, what's going to happen at 24 hours, and what's going to happen at 36 hours, and so on. So, remember, at the food that you have taken will be producing glucose for approximately around 4 to 5 hours for variable period, depending on the glycemic load that you have taken. It can contribute to the glucose for 4 to 5 hours. Beyond that, you need a different biochemical pathway to take over to produce glucose and run your body to produce energy and ATP. So for that, at 6 hours mark, the glycogen is going to be the major source of energy, and more than 80% of the glucose that is present at 6 hours is actually coming from glycogenolysis. But subsequently, the glycogen stores will get depleted faster. By around 24 to 36 hours, there will be literally no glycogen left, which means glycogenolysis cannot contribute to a significant source of glucose and energy at around 24 to 36 hours, which means there will be a complete depletion of glycogen by that time. Gluconeogenesis, yes, at 6 hours contributing a very little to the glucose that is circulating. But at 12 hours it expands, at 24 hours it expands the maximum, reaches a peak. Beyond that, it will not rise and it will become a plateau. But later stages, beyond 24 to 36 hours, your ketogenesis and production of ketone bodies are going to become really, really important. And this is what we refer to as a fasting or a starvation ketosis. And that's going to act as one of the very, very important source of fuel along with free fatty acids. Because when you have ketone bodies, means you're having free fatty acids as well. So which means at around 36 hours, your ketone bodies will take over, where ketogen is going to be the most important source of energy along with the free fatty acids, where there will be still some amount of gluconeogenesis going on, and there will be some amount of glucose that will be produced from gluconeogenesis, which I've shared in red. And that amount of glucose is important for utilization by the brain and more importantly the RBCs. And literally there will be no glucose production from glycogen, which means there will be significant and severe glycogen depletion, where there will be literally no glycogen to produce glucose anymore from glycogen. And this tells you some crucial points as well. For example, if you develop hypoglycemia by around 6 to 8 hours of fasting. So if you have not taken feeds for 6 to 8 hours and if you develop hypoglycemia, especially a child who develops hypoglycemia in that circumstance, usually denotes a glycogen metabolism defect. Because glycogenolysis is very important for the 6 to 12 hours to produce glucose. If that is defective, that is the time where you're going to get hypoglycemia. Similarly, other pathway defects like gluconeogenic defects or probably your fatty acid oxidation defects, all these things will result in hypoglycemia after 12 to 24 hours. So which means if you have hypoglycemia after a prolonged fasting, like after 12 to 24 hours, you might think about alternative pathway defects like gluconeogenic defects and fatty acid oxidation defects. Let us discuss all these things in a graphical way. What I told you some time back. Like for example, as I told you, the exogenous or the dietary glucose is going to be the major source of glucose and energy in the body for approximately 4 to 6 hours depending on the amount of glycemic load that you have taken. By around 4 hours, the glucose from the diet would have got depleted, and that time glycogen will take over, and glycogenolysis is going to be the major source of glucose at that point of time, where it starts kicking by around 4 to 6 hours, reaching a maximum by around 8 hours, and slowly it starts declining after that. By around 24 to 36 hours, there will be no more glycogen that is left in the liver to contribute to the glucose. By around 6 to 8 hours, your gluconeogenesis will start increasing a little bit. By around 12 to 24 hours, it peaks, and beyond 24 hours, it will reach a plateau, where beyond which gluconeogenesis cannot be expanded to produce glucose. And let us see some of the endocrine regulation. This we have discussed already in the basic section, but let us review one more time because it's important for hypoglycemia understanding. So as I've already told you, insulin is the only hormone to produce hypoglycemia in the body. Even though there are some factors like insulin, like growth factors 1, 2 and all these things can produce hypoglycemia in excessive amounts, the setting of probably a malignancy. But per se, they are not going to play a major role in the setting of physiological as well as pathological mechanisms. Insulin is the only major hormone that's going to produce hypoglycemia, and you have to be very clear about that. So how insulin does that? Insulin literally acts on every single pathway that produces glucose, thereby downregulating all these pathways to reduce the glucose production and cause hypoglycemia. For example, insulin can inhibit glycogenolysis, insulin can inhibit gluconeogenesis, insulin can inhibit lipolysis, and insulin can inhibit ketogenesis and ketone body production as well. So which means this is the only hormone which has a hand on all the different pathways of glucose production. So insulin does that by inhibiting certain enzymes. For example, it can inhibit glycogenolysis by inhibiting glycogen phosphorylase and stimulating glycogen synthase, and it can inhibit gluconeogenesis by inhibiting all the key enzymes that are necessary for production of glucose through gluconeogenesis. So for example, its major action is on the pyruvate carboxylase, but it can still inhibit the fructose 1,6-bisphosphatase and glucose 6-phosphatase enzyme. Insulin can suppress lipolysis by its strong effect on hormone-sensitive lipase, where it's going to inhibit it, and it can reduce the ketone body production by strongly stimulating acetyl-CoA carboxylase, thereby shunting acetyl-CoA towards fatty acid production rather than ketone body production. So you can remember insulin like sort of a kingpin, which is going to have its effect on all the major biochemical pathways that are going to produce glucose. So to counteract this kingpin, you are having 4 counter-regulatory hormones that act in synchrony and conjunction to oppose the effects of insulin. For example, you have glucagon to do that, you have epinephrine to do that, you have cortisol to do that, and we have growth hormone to do that, where the 2 most important counter-regulatory hormones are glucagon and epinephrine, of course. Glucagon counteracts the effects of insulin by stimulating gluconeogenesis as well as glycogenolysis and ketogenesis and subsequent ketone body production, but it has no major effect on lipolytic pathways. Whereas epinephrine can stimulate glycogenolysis, lipolysis and ketogenesis, whereas it has no major effect on gluconeogenic pathways. Cortisol has its major effect on stimulating gluconeogenesis, whereas it has no major effect on other biochemical pathways that produce glucose, whereas growth hormone is going to stimulate lipolysis and it has no major effect on other glucose producing biochemical pathways. So in a nutshell, I can tell glucagon is going to stimulate all biochemical pathways that produce glucose except lipolysis, whereas epinephrine can stimulate all major biochemical pathways that produce glucose except gluconeogenesis, and cortisol's effect will be predominantly on gluconeogenesis and growth hormone's effect will be predominantly on stimulating lipolysis respectively. So this also tells a point that deficiency of only one counter-regulatory hormone is not going to result in hypoglycemia, which means the setting of a cortisol deficiency, which can happen in adrenal insufficiency or pituitary insufficiency, is not going to usually result in hypoglycemia by itself. It can increase insulin sensitivity, but it doesn't mean that they're going to have increased attacks of hypoglycemia. So which means if there is some pre-existing condition that is going to result in hypoglycemia, cortisol deficiency will add on and they will accelerate the development of hypoglycemia, but cortisol deficiency alone cannot produce hypoglycemia unless and until other pathways are also deranged, which we'll be discussing subsequently. There is an entity called hypoglycemia-associated autonomic failure, which happens in type 1 diabetes mellitus. So type 1 diabetes mellitus patients, as a part of autonomic spectrum, if they have adrenal insufficiency also, then there is a high chance of developing recurrent and severe hypoglycemias. So fine, let us now move on to the physiological defenses that happen in the time of hypoglycemia. Of course, hypoglycemia means low glucose, and this can be sensed by 2 major organs. One is going to be the brain and second is going to be the pancreas itself. So where the beta cell senses this low glucose and they are going to reduce the insulin production and secretion. And you know, beta cells insulin secretion and production is glucose dependent. That's what we call it as a glucose dependent insulin release. So whenever there is low glucose, there's going to be low insulin, and this will be sensed by the alpha cells, because insulin and glucagon are considered to be like sort of an antagonist to each other. So whenever there is low insulin, that's going to actually reflexly trigger the production of glucagon from the alpha cells. So low insulin, you will have high glucagon. When you have high insulin, you will be automatically having low glucagon. So this is going to result in reduced insulin-glucagon ratio, which is actually the most important, because that ratio is the one that is actually sensed by the organs, especially the liver, which is going to increase the glucose producing biochemical pathways like glycogenolysis and gluconeogenesis, both of which will be accelerated because there is a reduced insulin-glucagon ratio, which means it's like a catabolic state and a low energy state in the body. So once this pathways are accelerated, that's going to result in excessive glucose release into the blood to be used by other organs in the body. And brain also can sense this hypoglycemia and they can stimulate the sympathoadrenal outflow, because this is like an emergency scenario. Of course, in emergency scenarios, you have to stimulate the sympathoadrenal outflow from the brain. which means it's simply nothing but the sympathetic nervous system. So first, as I told you, it's a sympathoadrenal pathway. They're going to stimulate the adrenal medulla, which is typically under the control of sympathetic nervous system, to produce epinephrine. And we know what is the importance of epinephrine, because epinephrine can work on the muscle to produce amino acids and lactate, because epinephrine being catabolic, they are going to degrade the proteins to produce amino acids, especially gluconogenic and ketogenic amino acids. For that matter, let us take alanine, for example. And once again, they are going to produce lactate as well. And this will be utilized by the liver for the gluconogenic pathways to produce more glucose. And this is what we refer to as a Cahill cycle and Cori cycle respectively, where alanine that is produced by the muscle will be utilized by the liver to produce glucose, which will be utilized by the muscle in return, where lactate that is produced by the muscle, which will be utilized by the glucose to produce glucose, which can be further utilized by the muscle. So we call it as a Cahill's and the Cori cycle respectively. And of course, this increased epinephrine is going to work on the adipose as well. By working on the adipose tissue, they are going to produce lipolysis, because catecholamines are going to stimulate the hormone sensitive lipase, where they can produce free fatty acids and glycerol, where the glycerol will be utilized for the gluconeogenic pathways to produce glucose, and free fatty acids can be utilized over time to produce ketone bodies. And this free fatty acids also has one important function, where it can be a major source of energy for glucose and adipose as well as the muscle itself, and they spare glucose and they increase the blood glucose content to be used by the other organs that depend on glucose, like brain and RBCs in the early stages. Now, increasing sympathoadrenal outflow means they are going to increase the neurotransmitters as well, like norepinephrine as well as acetylcholine, because acetylcholine can also be released by the sympathetic nerve endings, especially the cutaneous areas that produce sweating. So increased norepinephrine will result in production of certain symptoms of hypoglycemia, like tremors, tachycardia, which will subsequently result in palpitations. And increased acetylcholine can result in sweating, coupled with certain parasympathetic symptoms like hunger. All of these things are what we refer to as something called classic neurogenic symptoms that happen in the setting of hypoglycemia. These neurogenic symptoms are going to result in increased food intake by the patient, because patient knows that they have to take food to abolish these neurogenic symptoms, and that will result in increased glucose entry into the body by absorption of glucose from the gastrointestinal tract. And as we understood, we know very clearly that it's not only about the insulin that is declining during the time of hypoglycemia is important, it's also about the counter-regulatory response that plays a very, very important role in the defense against development of serious hypoglycemia, and especially in the setting of type 1 and type 2 diabetes mellitus patients. If you have a defective counter-regulatory response, that actually predisposes to the development of serious and recurrent hypoglycemias in these individuals. Especially if you don't have a sufficient epinephrine response to defective sympathoadrenal outflow from the brain, that is typically termed as something called hypoglycemia-associated autonomic failure. And that's what we're going to see next. So what's going to happen in a normal individual or someone who's suffering from a early type 2 diabetes mellitus? So whenever the glucose is reducing in the setting of hypoglycemia, the insulin production will drop from the beta cells appropriately, because the insulin release and production from the beta cells is actually glucose dependent. We know that. So once the insulin levels drop in the blood, glucagon automatically rises, because that alpha cells are going to sense this drop in insulin and they're going to subsequently increase glucagon. And of course, the brain is also going to sense this hypoglycemia, and they're going to increase the sympathoadrenal outflow, causing excessive epinephrine. This is an appropriate and a normal response to hypoglycemia. But in the setting of a type 1 diabetes mellitus or someone who's having a late stage of type 2 diabetes mellitus, things are going to work differently. In that setting, if you have a hypoglycemia, the insulin response may be defective, which means the decline in insulin may not happen that greatly. There's a lot of reasons for that. So one reason that is postulated is the beta cells will be very much confused with hypoglycemic attacks. For example, it's been postulated that if you have an attack of hypoglycemia, there will be lowering of the threshold for decline in insulin from the beta cells, which means if I already had an episode of hypoglycemia like 50 or 40 milligrams per deciliter, the beta cells would have lowered the threshold for lowering the insulin, which means during the next attack, unless and until you reach that particular glucose value, the insulin production will not decrease or insulin release will not decrease. So that is called lowering of the threshold for insulin release from the beta cells, number one. Apart from that, second reason is because of chronic glucotoxicity that is happening in the setting of chronic long-standing diabetes. These individuals may have defective beta cells, but which may not be able to reduce the insulin production. Reason number three, in type 2 diabetes mellitus, patients that have been taking secretagogues like sulfonylureas, which will not allow the beta cells to reduce the insulin production, because once you take sulfonylureas, anyways they are going to block the ATP sensitive potassium channels continuously, and that will result in continuous outpouring of insulin despite the fact that they are having hypoglycemia. And number four, if the patient is a type 1 diabetic, they will be taking some exogenous insulin. Even though the beta cells tend to suppress their insulin production, this exogenous insulin will not allow the blood insulin to fall, resulting in a poor fall in the insulin levels in the blood. So anyways, no matter what, the glucagon levels also will not rise subsequently, because the glucagon rise is based on the insulin. It's high insulin means low glucagon, and low glucagon means high insulin. So this is how it is. So if there is no change in the insulin, there will be not much change in the glucagon release from the alpha cells as well. And this is going to be the basis of treating with glucagon in hyperinsulinemic conditions. So whenever there is a patient who's coming with hypoglycemia due to hyperinsulinemic state, like sulfonylurea use, or like patient who's using exogenous insulin, or in the setting of insulinoma itself, if you give glucagon, it will produce a good response in the blood glucose levels. Because in the setting of hyperinsulinemia, your glucagon levels will be low. So when you rise the glucagon, automatically it's going to produce a good response in the blood glucose. Suppose if you are having a condition which is producing hypoglycemia, but not due to hyperinsulinism, so which means the insulin levels are already low in them, because hypoglycemia would anyway lower the insulin levels, because the hypoglycemia here is not due to hyperinsulinism. So because there is low insulin, the glucagon levels would have been high. So already the glucagon levels are high. In this condition, if you put a glucagon injection, it's not going to work, because glucagon is already in the peak. So that's the basis of using glucagon injections to treat hypoglycemia caused by hyperinsulinism, by insulin secretagogues like sulfonylureas, by exogenous insulin causing hypoglycemia, and finally for insulinoma causing hypoglycemia as well. Fine. So apart from that, there can be blunting of the epinephrine response as well, because of the blunted sympathioadrenal outflow from the brain. And this can happen especially in the setting of a type 1 diabetes mellitus and a long-standing type 2 diabetes mellitus, and this is given a special terminology and name called as hypoglycemia associated autonomic failure, or HAF. And hypoglycemia associated autonomic failure gives rise to a big headache, because they result in something called a hypoglycemic unawareness, which means the sympathetic symptoms that you develop are one of the most important reasons why you know that you are going to develop, or you are developing hypoglycemia, and subsequently you result in some counter-regulatory actions like eating food. And if you don't have that awareness, then you will not be knowing anything about hypoglycemia that is happening in the body, and until you get knocked out because of neuroglycopenic symptoms. And why you develop hypoglycemia associated autonomic failure in the first place? And there are a lot of theories, but one reason is the fact that one attack of hypoglycemia might actually lower the brain's capability for sensing hypoglycemia for the next time. It's like a resistance you develop. Or you can imagine like how we remembered for the beta cell, like there is a lowering of the threshold for release of sympathioadrenal outflow during the time of hypoglycemia. So once you get a blood glucose value of maybe 40, 50, so your brain will think that, probably this is the threshold where you should release, like your sympathioadrenal outflow. So next time, until you reach that 50 or 40, your brain will not release sympathioadrenal outflow and will not produce subsequent autonomic symptoms. And if you get another attack of hypoglycemia, the threshold will be even more lowered. Subsequently, there will be more and more resistance to sympathioadrenal outflow because of hypoglycemia. So that is probably one reason why you are generating this hypoglycemia associated autonomic failure, but the reason is not very clearly known. But it's also important to know the fact that this hypoglycemia associated autonomic failure is not equivalent or synchronous to another terminology called as autonomic neuropathy, which is very common in the setting of diabetes mellitus. Even the autonomic neuropathy can worsen the hypoglycemic unawareness in the individual, but both terminologies, that HAF and autonomic neuropathy, are not synchronous to each other. So there is one classic clinical point that you have to know here. As I told you, hypoglycemic unawareness is due to lowering of the threshold for release of autonomic symptoms and release of sympathioadrenal outflow from the brain caused by previous hypoglycemia. So if you prevent hypoglycemia from happening for a variable period of time, the awareness can be restored or the threshold can be raised. So that's the classic idea. Suppose any patient who's coming with recurrent serious hypoglycemias, especially in the setting of type 1 diabetes mellitus where it's extremely common, put a continuous blood glucose monitoring and make sure that they don't go for hypoglycemia for the next few days to weeks. If you do that, automatically the threshold will be raised and they will be able to sense hypoglycemia once again. That is called as restoration of hypoglycemic awareness. So that can be done by preventing hypoglycemia from happening for a period of days to weeks over time. And that's very, very important in the setting of type 1 diabetes mellitus when you are treating with intensive insulin therapy. And hypoglycemic unawareness can be caused by many other drugs. Like for example, beta blockers, especially if you are giving a non-selective beta blockers, the hypoglycemic unawareness may be even more severe. Because beta blockers can blunt certain symptoms of sympathetic nervous system like tremors, tachycardia and so on. So that's why you have to be very careful in that setting, because beta blockers are very commonly used in the setting of type 2 diabetes mellitus because majority of these patients will be having some underlying cardiovascular problems. So beta blockers are not contraindicated, but you have to be very careful because they can worsen the hypoglycemic unawareness caused by the pre-existing hypoglycemia associated autonomic failure. So with this understanding, let us move on and discuss on the physiological response or the effects that we have been seeing till now in response to hypoglycemia. So whenever the blood glucose values are less than 50 milligrams per deciliter, at this point, there is no business for insulin to exist in the blood because insulin released from the beta cells are glucose dependent. At hypoglycemia, there should not be any insulin release, which should be appropriately suppressed to less than 2 mu per ml. And ketone body production will increase because of low insulin coupled with higher counter-regulatory hormones. Definitely ketone body production will be appropriately increased to more than 2 to 2.7 millimoles per liter. Even though the values vary, the concept is important here. And the lactate production will be suppressed because even though the lactate is produced from the muscle, it will be utilized by the liver for gluconeogenesis. So it will be appropriately suppressed to less than 2 millimoles per liter. And cortisol and growth hormone being counter-regulatory hormones, definitely their level should be high, where cortisol should be appropriately high to a level more than 515 nanomoles per liter, and growth hormone levels also should be appropriately high to a level more than 10 nanogram per ml. And we have already discussed in detail about this glucagon release and glucagon response in hypoglycemia. So if it's a physiological, non-hyperinsulinemic hypoglycemia, for example, if the blood glucose goes below 50, and if it's physiologic, so of course your beta cells are going to reduce insulin production, and this will be sensed by the alpha cells to produce more glucagon. So when you're giving an exogenous glucagon here, already the glucagon is high, and what extra advantage is going to produce? So the blood glucose rise, if it's a physiological hypoglycemia, will be less than 25 milligrams per deciliter after giving glucagon injection. But this is a very important thing to know because in hyperinsulinemic hypoglycemia, because the insulin levels are high, the glucagon will be low. And giving a glucagon injection here and rising the glucagon will result in a good response in the blood glucose to more than 25 milligrams per deciliter rise. So there are two quintessential evidences to tell that the hypoglycemia is due to hyperinsulinemia. One is suppression of the ketone bodies, because insulin is a strong anti-ketotic hormone. So when there is a hyperinsulinemic hypoglycemia, the ketone body production will be suppressed and the ketone bodies will be very, very low. And the glucagon related blood glucose response will be very good in the setting like if you give a glucagon injection, there will be rise of blood glucose by more than 25 milligrams per deciliter. These are very important to understand the future concepts and approach to non-diabetic hypoglycemia, which we'll be discussing subsequently in the next chapters. So let us come to the clinical effects and the clinical timeline for hypoglycemia. Suppose if you are having a blood glucose of 100 milligrams per deciliter, we know it's a normal blood glucose, so you're going to have a normal insulin secretion at this point from the beta cells. Above this, you'll have increased insulin secretion. Below this, you'll have reduced insulin secretion, which means at 80 milligrams per deciliter, you're going to have a reduced insulin secretion. It will not completely stop, but there will be reduced insulin secretion from the beta cells. At around 65 milligrams per deciliter, you will start producing counter-regulatory response. Your counter-regulatory hormones will start increasing. Epinephrine and glucagon are the most important counter-regulatory hormones, but apart from that, GH and cortisol also starts increasing at this point to a great level. At around 55 milligrams per deciliter, you will start experiencing the classic neurogenic symptoms of hypoglycemia like tremors, palpitation and tachycardia, sweating, hunger, anxiety, all these things will start. But remember, the onset of symptoms is going to have a great deal of variation among patients. There are certain patients who can develop neurogenic symptoms at 70, 65 itself. There are some patients who can develop neurogenic symptoms only at 40, 30. So it is having a great deal of difference depending on what the phenotype of the patient is, whether they are diabetic or not, how long they are diabetic, what about the HAF component, and whether they're using insulin or not for a long time. So all these things will tell at what point they're going to develop neurogenic symptoms. But arbitrarily, by around 55 milligrams per deciliter, one will start developing neurogenic symptoms at physiological state. But you can tell somewhere around 55 to 65 will be the ideal answer. So where they start developing neurogenic symptoms. And at 50 milligrams per deciliter, there will be absolutely no insulin release from the beta cells. The beta cells will completely shut down their insulin production and release. At around 40 milligrams per deciliter, you are going to get neuroglycopenic symptoms. And once again, this is little variable depending on the phenotypes which I have told you already. So they are going to get neuroglycopenic symptoms under normal physiologic states, which includes symptoms like jitteriness, headache, and in fact even severe symptoms like ataxia, seizures, apnea, and even coma. They can be completely knocked out. And hypoglycemia is a great mimicker. It can mimic anything. It can mimic a stroke, it can mimic a TIA, it can mimic anything. And they can produce certain muscle effects as well, because sudden lowering of the glucose will make the muscle not responding properly, and poor utilization of the glucose in this setting will result in weakness if it's affecting the skeletal muscle, or they can even go for cardiac failure and arrhythmias if it's affecting the cardiac muscle. So they can develop muscle effects as well, and hypoglycemia can cause sudden death and even a adverse long-term neurological outcome as well. And at a level of 20 milligrams per deciliter, your neuronal damage will start, because brain has stores of glucose that can last only for 2 minutes max, not beyond that. So if you have a very serious hypoglycemia and for a long time, there can be neuronal damage, which can be sometimes permanent also. And again, it depends on the sensitization of neurons to prior episodes of hypoglycemia. Fortunately, in type 1 diabetes mellitus patients, because of continuous hypoglycemia for a long period of time, the threshold is lowered and the neuronal damage also will be less compared to that of the other patients. If I am getting hypoglycemia suddenly now, I might be having a long-term neurological sequelae, but because type 1 diabetes mellitus patients are continuously exposed to hypoglycemic attacks, their neurons will be adapted to that. And fortunately, despite getting multiple attacks of hypoglycemia, a lot of trials have proven that these patients are not having long-term risk of dementia as of now. And after knowing the timeline, so final thing what we have to know is the Whipple's triad, because this is the gold standard triad for confirming the existence of hypoglycemia in the patient. So first of all, Whipple's triad tells that the patients will have symptoms and signs of hypoglycemia, which we have been discussing for quite a long time. Coupled with that, there should be documentation of that hypoglycemia by some value like plasma glucose, which is the gold standard, but sometimes can be the CBG value also, capillary blood glucose also. But there should be some documentation of that blood glucose value. It's a documented hypoglycemia. And finally, there should be alleviation of this symptoms of hypoglycemia with glucose administration. So remember the fact that this Whipple's triad is not specific for one particular disease. This Whipple's triad is the gold standard for telling that this patient is probably suffering from problems due to hypoglycemia. That's all. This is an hypoglycemia triad rather than being an insulinoma triad or something else, because this triad can be seen in sulfonylurea producing hypoglycemia. This triad can be seen in insulinoma producing hypoglycemia. This triad can be seen in any patient who's having any other reason that produces hypoglycemia. But you have to be very careful, especially when you are using a capillary blood glucose, because capillary blood glucose can be unreliable at extreme levels, even at very high levels, at very low levels also. So plasma glucose is going to be the gold standard for documentation of hypoglycemia. Number one. At the same time, if your sample processing is late, if you process the sample late, even if it's a plasma glucose, plus if you are not using sodium fluoride tube, And that's going to be a problem again, because that gray vacuum sodium fluoride tube is a must whenever you are using a venous sample for measuring blood glucose. So in this circumstance, definitely the blood glucose levels will drop by 10 milligrams per deciliter per hour, which you have to keep in mind. So if you are not using sodium fluoride vacuum process the samples as fast as possible. But better is to use the sodium fluoride vacuum always. And remember, there is a difference between blood glucose versus plasma glucose, where the blood glucose will be usually 10 to 15% lower than the plasma glucose. And this effect is augmented in the setting of polycythemia. We know that because RBCs are more in polycythemia, so they're going to use more glucose. And you have to be aware of that fact. So these are the things that you have to know as a hypoglycemia basics. With this, we are going to complete this particular chapter. In the next chapter, we'll be discussing on the evaluation approach of hypoglycemia to infants and children.